Yes, thank you, and good morning to all of you. Thank you for attending this presentation, and thank you to our moderators for getting up early to do this for us. In the next two presentations, I'll be sharing some information about the different microbes that are related to recurrent urinary tract infection in adult women. And in the second presentation, I'll be talking about the possibility that the urethra is a separate niche microbial niche in the lower urinary tract. This study was led by two of us from two different institutions who are still collaborating in one research group. And Bailey Hochstetter was in the lead in the laboratory, and Kiri Jung was in the lead in the clinical area under my direction and my collaborator, Dr. Alan Wolf from Loyola. These are the disclosures we have. Mine are limited to my editorial responsibilities, and Dr. Wolf has investigator-initiated grants from Astellas and Kimberly-Clark. The aims of our first study were to characterize the urinary microbiota involved in recurrent urinary tract infection and compare the techniques of the standard urine culture and the newly described expanded quantitative culture, and then also compare paired specimens that were collected from the same patient through a transurethral catheter or a voided specimen. In this study, we assessed 37 patients who provided a midstream urine first and then underwent transurethral catheterization for clinical indications as part of their normal evaluation. All the samples were cultured under standard conditions by the standard urethral culture technique and the expanded quantitative urine culture technique described yesterday in my plenary talk. The bacterial isolates were identified by MALDI-TOF mass spectrometry as standard in any clinical laboratory, and the primary outcome measure that we looked at was the microbiota presence and abundance between the culture methods and the paired samples within a single participant. The 37 patients had a median age of 70 with a range of 32 to 90. Most were postmenopausal. Most of the postmenopausal patients were using low-dose vaginal estrogen, typically 10 micrograms of estradiol twice a week. 76 had reported recent antibiotic use, and their antibiotic use was related to the reported 52 lifetime UTIs in a lifetime, so significant UTI burden in this patient. And about a third estimated that they had a UTI at this visit, although their symptoms are very highly variable in this patient population. These are the techniques that we use for the culture conditions. These have been published and are easily available. This technique can be done in any clinical laboratory. Note that in the EQUIC, we also use anaerobic conditions with longer incubation and higher urine volume. This is the unique species detected. And so we look to see whether the standard urine culture compared to the expanded culture were similar, and the expanded culture typically harvested many more identifiable unique species. In this group, we found that Enterococcus faecalis was the most frequently detected microbe. Unlike the typical dogma that E. coli is the most common uropathogen, so we saw more uropathogens by EQUIC, and the distribution was different when assessed by EQUIC, with Enterococcus being the most frequently detected. Here's the self-report status, with about 13 of these patients thinking they had a UTI, the majority thinking they didn't. And you can see in the group that thought they had a UTI, Enterococcus was more prevalent. 2 of the 3 E. coli positive women who self-reported UTI were also culture positive for Enterococcus faecalis, giving rise to the term of a polymicrobial UTI. Most typically, we think of a single microbe causing UTI, and it's probably time for us to change our thought about this. This is just some diagrams of the different microbes. On your left side is a comparison to historical controls, 75 patients who did not have recurrent UTI but thought they had UTI. 49% of them in the yellow thought that had UTI grew E. coli, whereas in the recurrent population here, only 13% did, but 38% of the black group did not amplify And Mike, in answer to your question, we think that this is a sub-threshold issue as opposed to being sterile. We're not clarified on that yet. In summary, eQuick definitely detects more unique species and more potential uropathogens, including anaerobic microbes that are not typically cultured in the standard urethral culture, which misses 98% of known cultivatable organisms. The higher frequency of unique species and uropathogens is found in voided urine, which may lead to an overdiagnosis of actual clinical infection. We found that Enterococcus faecalis is the most prevalent uropathogen, and that the microbiota profiles differ significantly in women with recurrent UTI as opposed to that with sporadic acute UTI. We think that symptomatic recurrent UTI that's being diagnosed by standard urine culture may miss some of the causative uropathogens, and we have an opportunity to improve our clinical care there and target treatment more appropriately and exhibit better antibiotic stewardship in our clinical care. And that we raise the question with this, that we wonder, given the differences in the voided specimens, whether the urethra could be a reservoir, and I will address that in the next talk.
We can have questions now if they're highly important. We're going to do them together, but go ahead.
My name is Grobe from University of Pittsburgh. Do you find any difference of bacterial status between estrogen replacement patient or not?
Similar to what Professor Glavin showed, when there was estrogen replacement, we saw a higher proportion of lactobacillus in the urinary symptoms, but it's a different lactobacillus subspecies that normally lives in the vagina. So it's lactobacillus, but we find that the vaginal and the bladder are different in that regard.
Thank you.
Thank you.
Hi. Is Dr. Moore?
Kate Moore from Sydney.
Hey, Kate.
Hi. As regards polymicrobial UTI, this is a huge issue that we found in a group of refractory DO people last year, that the laboratory doesn't want to release the polymicrobial UTI because the microbiologists are worried about too many antibiotics being prescribed. So could I ask your thoughts on, you were commenting on antibiotic stewardship. Are we opening up a can of worms? Indeed, the polymicrobial UTI must be important for these patients, but what are we going to do about giving them more and more antibiotics? Are we going to get some other way of approaching these people, like anti-inflammatories or something?
Yeah, Kate, so thank you for the work that you've done. It's really contributed to the literature in a meaningful way. It really is sort of an editorial comment. First of all, I don't think we know really what a UTI is anymore. And I think it's a little paternalistic for the non-physicians in the microbiology lab to tell us. I think they owe us a complete information profile. And then we need to learn that the approach is not to kill every bacteria. That we need to modulate that microbiome back to a state of health by whatever mechanisms are available. And antibiotics may play a role in some patients and not in others. And so I think we have a big learning curve ahead of all of us. It will make learning the electronic medical record easy compared. This will be much harder than that. So, but thank you for the work you've contributed, Kate. It's been significant.
Scott Glickman from the UK. I'm also very naive about this whole microbiome story. So my question to you is, on which side of the urothelial cell membrane do you think the problem is actually residing? Is it planktonic dysbiosis, or are we talking about bacteria actually invading that we're not actually identifying?
I think that's a very insightful question. Where are these bacteria? And I think any and all of the above are possible. And of course, we are very, very limited in our ability to diagnose certain niches here in certain locations of these bacteria. And we've had elegant descriptions of intracellular bacterial communities. We are really hampered in our ability to clinically detect that, or biofilms. And in those areas, phage therapy may be more effective. We're just too early in our research to make comments on that.
It raises the question whether an MSU is even relevant.
I wish I had said it as well as you did, yes. Whether MSU is even relevant, So let's talk about the urethra.